Good evening, lovies. Hope you're okay and you've all had a good week. Today I'm talking about, it's a bit of a strange one, but it's about what can happen if you're not diagnosed with hypermobility in time for physio to help you manage it for the rest of your life. So the title for tonight is The Pain They Missed, Hypermobility, Patellofemoral Pain and Taking Your Knees Back. So welcome back to the podcast. I'm Becky, your host, and this is Be Yourself Unapologetically. Today we're talking about a kind of pain that doesn't just live in your knee. It lives in your sleep, in your mood, in your daily life. We're talking about what happens when childhood hypermobility is dismissed as being bendy or growing pains, and how that can turn into patellofemoral pain and chondromalacia patellia. You know, the big words, but it just means, that your knees grinding and the stabbing agony behind the kneecap later in life. And if you've ever been told your x-ray looks normal while you're lying awake at 3 a.m. because your knee feels like it's full of broken glass, then this episode is for you. A quick disclaimer before we dive in: I'm not your doctor, I'm not giving you personal medical advice, I'm sharing education, validation and questions you can take to your GP, physio or specialist so you can fight for the care you deserve. Always check anything I say with a qualified professional who knows your medical history. Right, let's talk about the knees they forgot about. The bendy kid that nobody joined the dots for. Maybe this was you. You were the bendy kid. You could straighten your elbows past straight. Your knees hyperextended. You sat in weird positions. Adults said things like, wow, you're flexible. Or, that's just growing pains. You're double jointed. You'd be brilliant at dance or gymnastics. No one said, hang on, this might be joint hypermobility. We should check how your joints are coping. We should protect them. So you carried on, PE lessons, running around, sitting cross-legged, twisted, slumped, maybe your knees clicked, ached on stairs or hurt after sports, but you were told to just walk it off. Fast forward 20 or 30 years and now your knee is screaming when you go upstairs or downstairs, get in and out of the car, using the clutch, sitting for too long then trying to stand up, squatting or kneel. Try to sleep with the duvet touching the front of your knee. I should have noticed this. This is the weirdest thing, right? I've always had dodgy knees. But I remember getting an exercise bike. Now, when I was younger, it didn't really hurt that much. I used to use one quite a lot. But as I got older, using like a treadmill would really hurt my knees. Using an exercise bike would really hurt my knees. I just put it down as being unfit. Because, that's what you do. But it's like, even when the duvet is touching your leg and it's like it hurting you too much, then, something needs to be done. Because if you're trying to sleep and the duvet is touching the front of your knee and it's causing them much pain, then something should be done. It's like you did exactly what adults told you. You present, but you is paying the bill. So hypermobility isn't just a party trick. For some people it's harmless. For others it means looser, less stable joints. And if that instability isn't supported with proper muscle strength and alignment, something has to take the strain. And often that something is the cartilage behind your kneecap. So what actually is patellofemoral pain and chondromalacia patellae? Let's de-jargon this for you. Your knee is where your thigh bone, the femur, and shin bone, the tibia, meet, okay? So these meet where your knee is. And on the front sits your patella, your kneecap, a little bone that glides up and down in a groove at the front of the femur when you bend your leg or straighten your leg. But patellofemoral pain is a broad term for pain around or behind the kneecap, where the patella meets the femur. Chondromalacia patellae literally means softening or damage of the cartilage of the underside of the kneecap, the smooth tissue that's meant to let it glide comfortably. In a happy, well-aligned knee, the kneecap tracks nicely in that groove, the cartilage is smooth and movement is boring, which is what we want from our joints. In a knee with patellofemoral problems, one or more of these things may be going on. The kneecap doesn't sit centrally, it's pulled slightly to one side. The muscles around the hip and thigh are out of balance. The leg alignment encourages the knee to fall inwards. The cartilage under the kneecap has become irritated, roughened or worn. The result? Pain at the front of the knee that's often worse with stairs, squats, kneeling, getting up from sitting or walking downhill, sometimes associated with crunching, grinding or clicking when you move the knee. I mean, I've always had clicky joints, but I really didn't know that that was something until recently my daughter was diagnosed with hypermobility. So there you go, we learn something every day. But the thing is, this now has just got so bad because you just get on with it, because when you're my age, when you were younger, people just said, oh, it's growing pains. But it's agonising if you've been sat for ages. The classic cinema knee. So add hypermobility into the mix. So how hypermobility that's been missed can set your knee up to fail. Hypermobility can affect ligaments, the straps that hold bones together, joint capsules, the connective tissue around the joint, tendons and fascia. If those structures are more lax, the joint may have a bit more give on its own. That's not automatically a problem, but you need strong, well-coordinated muscles to control that extra movement. If as a child or teen you were bendy, but not especially strong, you stood with your knees locked back, feet turned in or out, you did lots of impact activity without good conditioning, your pain was brushed off so you never got physio or support, then the way your kneecap tracked with every step might have just been slightly off. Not enough to dislocate, but enough to cause micro irritation and uneven pressure on the cartilage year after year. Chondromalacia patellae is often linked with poor kneecap alignment, muscle imbalances in the quadriceps, flat feet or overpronation, hypermobility, previous knee injuries. Missed hypermobility doesn't just mean no diagnosis. It often means no tailored advice about pacing activity, no guidance on joint-friendly sports, no early strengthening program, no one explaining why your alignment and posture matter for your future. I mean, I'm terrible for doing things on my knees. I always have. Kneeling on concrete floors, just, there's times where I kneeled and it felt like something was stabbing me through the kneecap. Again, I just brushed it off. So here I am now, an adult me, so an adult you're maybe in your 30s, 40s or 50s. Your knees feel ancient and you're being told it's just wear and tear. It's not that bad on the scan. Take some pain relief. And it feels invalidating because the pain is very real. The emotional side of a misdiagnosis. Let's talk about the grief that comes with this. You might feel angry that no one listened when you were young, guilty like you should have looked after your knees better, scared, wondering if this level of pain is your new normal, invisible because the knee can look normal from the outside. If every step hurts, your world shrinks. You stop joining in walks, stairs become an obstacle course, you dread long supermarket queues, you plan your day around how many times you'll need to stand up. Chronic pain can drag your mental health down, especially if you feel like medical professionals haven't taken you seriously. I want you to hear this clearly. You are not imagining it. You are not weak. You are not a drama queen. You are someone living with a very real pain that deserves proper assessment and proper treatment. And no, you can't go back and reparent your childhood needs, but you can start taking fierce, informed care of them now. So, what can be done? Realistically, like, not magic wand. Let's be honest, if cartilage has been irritated or worn, we can't magically grow back perfect, brand new tissue overnight. But that does not mean you're stuck in agony forever. The goal is usually to reduce inflammation and overload, improve the way the kneecap tracks, build a support system of strong muscles and better movement patterns, keep you as active and independent as possible. So I'm going to walk you through the main areas that are commonly used. Remember, this is general information. What's appropriate for you personally must be decided with your GP or physio. So getting the right diagnosis and ruling out red flags. Step 1 is making sure we are dealing with patellofemoral pain and chondromalacia and not a fracture, a big meniscal tear, ligament rupture, infection, inflammatory arthritis. That usually involves a thorough history and physical examination, not just a 30-minute glance. Second glance. Wow, we'd all have 30 minutes with a doctor, wouldn't we? Sometimes x-rays to look at alignment and joint space. Occasionally an MRI if symptoms are severe or not improving and something else is suspected. This is where you might need to advocate hard. Write down your symptoms, how long they've been there, what makes them worse. Mention any history of hypermobility, frequent sprains or other joint issues. If you suspect a hypermobility spectrum disorder or something like HEDS, say that out loud and ask if a rheumatology or genetics referral might be appropriate. You are allowed to ask, is this definitely just pallitomyforal pain, or are we missing anything? Targeted physio can be a real game changer. For most people, it's the cornerstone of treatment. Multiple guidelines and studies support tailored exercise for patellofemoral pain and chondromalacia. Key components usually include strengthening the quadriceps, especially the inner part, the VMO. So gentle straight leg raises, mini squats or sit to stands within a pain tolerable range, leg press or step ups when you're ready. Hip and glute strength. If the hips are weak, the knee can collapse inwards, increasing stress on the patellofemoral joint. Exercises might include side lying leg lifts, clamshells, bridges, standing hip abduction with a band. Stretching tight structures, especially the quadriceps, the hamstrings, the calf muscles, iliotibial band, the tissue down the outside of the thigh. Tightness here can pull the kneecap out of its happy groove. Movement retraining. Your physio may look like at how you walk, how you go up and down stairs, how you squat and sit, whether your knees drop inwards, and then they'll coach you on safer patterns to reduce the stress on the joint. With hypermobility, physio might need to be slower and more gradual. Your joints may not like sudden overload. More focused on control rather than extreme stretching. Ongoing, think dental hygiene for your joints. Little and often, long term, not a 6-week burst and then done. Load management. What you do all day matters. Even the best exercises can't compete if you're constantly overloading the joint. That might mean reducing or modifying high impact activities for a while. Swapping deep squats and lunges for shallower, more controlled versions. Breaking up long periods of sitting, straighten your knee regularly. Be realistic about stairs, hills and kneeling. Instead of the old no pain, no gain, think some discomfort is okay. Sharp worsening pain is my cue to tweak things. A physio can help you find your sweet spot between doing nothing, which weakens you, and doing so much that you flare everything up. Pain relief and flares, calming the fire. While you're working on the long-term stuff, you're still allowed to treat the pain. You do not have to be a hero. Options your doctor might discuss include paracetamol or anti-inflammatory medication, topical anti-inflammatory gels around the knee, ice or heat, whichever subjectively feels better, short courses of stronger painkillers in acute flares if appropriate. In some cases, specialists may offer steroid injections, sometimes used short-term to calm a very inflamed joint, though repeated injections have downsides. Hyaluronic acid injections, a lubricant gel that can sometimes improve patellofemoral symptoms in selected cases. Again, this is individual. These aren't toys. Each option has pros and cons, so decisions should be made with a healthcare professional. Tapping, bracing and orthotics, giving the kneecap a guide rail. Some people get really meaningful relief from patella taping or braces that help the kneecap sit in a better position as they move. Taping is usually done by a physio at first, using specialised techniques. Braces and straps come in different designs. Some provide general support, others have pads to nudge the kneecap into better alignment. If you have flat feet or overpronation, shoe suits or shoe inserts or orthotics, things that you put in your shoes anyway, the posh name, can change the angle of your leg, which in turn changes the load of the knee. These don't usually fix the underlying problem on their own, but they can make it tolerable for you to do your exercises and daily life. Weight, strength and whole body health. This bit could be sensitive, so let's handle it gently. Extra body weight can increase the load going through the patellofemoral joint with each step, but chronic pain and mobility issues can make activity and weight management much harder. If weight is a factor for you and your healthcare team has mentioned it, the aim isn't blame, it's about seeing if small, sustainable changes could reduce stress on the joint. Equally important, good sleep as best you can manage with pain. Managing stress and mood, pain and anxiety feed each other. Treating any coexisting conditions like fibromyalgia, depression or other joint issues. You are not just a knee attached to a person, you are a whole person carrying a knee that needs some love. So when is surgery considered? The vast majority of people with patellofemoral pain, chondromalacia are managed non-surgically, but if you try thorough, high-quality, conservative rehab, you're still in severe pain, imaging shows significant structural issues that are surgically amendable, then a knee specialist might discuss options such as an arthroscopic tidy-up, debridement, basically, procedures to realign the patella in selected places. In more advanced arthritis, potentially joint resurfacing or replacement. Again, those are big decisions and the evidence for some procedures is mixed. It should be a careful shared decision with a specialist, not a rushed, we'll just have a look. Living with it day to day and keeping your hope. I want to acknowledge something. When you're in constant pain and someone says do these exercises or lose a bit of weight or just pace yourself, it can feel like they haven't heard how bad it actually is. Here are some realistic, compassion-filled truth. Progress is often slow and wobbly. You might have weeks where everything flares up and you feel like you're back to square one. That doesn't erase the gradual strengthening happening underneath. You're allowed to grieve the body you thought you'd have. The version of you that could run upstairs, kneel on the floor, or walk for miles without planning escape routes. Small changes are still changes. Being able to tolerate one extra flight of stairs, sleeping an extra hour, doing your exercises 3 times this week instead of none. You also deserve proper pain management and support while doing this. If one professional brushes you off, you are allowed to ask for a second opinion. You are allowed to say, "This is not manageable, I need more help." Your history matters. If you suspect hypermobility or hypermobility spectrum disorder and it has never been properly assessed, it is absolutely valid to raise that now. Earlier recognition might have helped, but later recognition can still change how your future is managed. So here's some questions that you can take to your GP or physio. If you're listening to this and thinking, okay, what do I actually do next? Here are some of the questions. Just screenshot it or write them down. It's entirely up to you. Could my knee pain be patellofemoral pain syndrome or chondromalacia patellae? Could my history of being bendy mean I have hypermobility that needs assessing? Would a referral to physiotherapy be appropriate, and can I have someone with experience in hypermobility and patellofemoral pain? Are there any red flag reasons I should be urgently investigated? Lock-in, giving away, infection signs, systematic symptoms, etc. Which pain relief options are safe for me right now? Would taping, bracing or orthotics be worth trying in my case? If things don't improve with conservative management, will we discuss specialist referral? You're not being difficult by asking these, you are being reasonable. So a message to your past and future self. To the child version of you limping around the playground with growing pains and clicky knees. You weren't overreacting, you were asking for help in the only way you knew how. The adults should have been more curious. To the current you, lying awake with an aching, grinding knee, your pain is valid, your frustration is valid, your exhaustion is valid. And to the future you, the one we're working towards, you might still have a sensitive knee, but it doesn't have to own you. With the right support, you can get stronger, wiser about your body and more in charge of your choices. Hypermobility might be part of your story. A misdiagnosis might be part of your story, but they do not get to the final chapter. So if this episode has spoken to you, please remember, nothing in here replaces a proper medical assessment. Use it as a script to self-advocate, not as a substitute for care. If you found this helpful, share it with someone who's being told it's just wear and tear while they quietly fall apart. Your knees might be noisy, but your pain shouldn't have to be silent. Thank you for listening, thank you for existing, and thank you for taking your body seriously, even when others haven't. So take care of your gorgeous joints, and I'll speak to you in the next episode.